Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Good morning, everyone, friends of LE&RN, friends and members of LE&RN. It's wonderful to see everyone again. Some of you I know, some of you I don't. Of course, I can't physically see you, but I see your names in the participant list. We have an exciting topic for you this morning. I think many of you know me. I'm Dr. Stan Rockson, and among other titles, I'm one of the co-founders of LE&RN and continue to serve as the chair of the Scientific and Medical Advisory Board of the organization. We're here today to talk to you about a very exciting study that we've been able to do, and it represents a part of a grant that LE&RN was able to get from the Centers for Disease Control, the CDC, of late, most famous for its role in all of the pandemic management, but of course they are involved in all sorts of disease management in the United States. And fortunately enough, we have been able to get the CDC to recognize lymphedema as a chronic disease worthy of study. And in that grant, I've serving as the principal investigator of the more academic side of the grant. The other part of it will be public education and healthcare provider education surrounding lymphedema. But as the academic portion of the grant, it became very important for us to understand what is the impact of lymphedema and how do lymphedema patients interface with the healthcare environment. And in order to answer those questions, we conducted surveys anonymously over social media, of course, with tremendous help from LE&RN's social media platform. And today we're going to present to you the results of that study, which will be published in manuscript form. So now it's my great pleasure to introduce my collaborator in this work, Catharine Bowman. She's somebody that you need to know because she represents the next generation of clinicians and scientists who will care for lymphedema and eradicate it as a problem, we hope. Catharine has nearly completed her medical studies at the University of Calgary, and we actually met when she was an undergraduate student. Fortunately, we were able to lure her here to Stanford, where she's pursuing a master's degree in epidemiology and is the recipient of a very prestigious scholarship, the Knight Hennessy Award. And Catharine has worked beautifully with me on this project and will now take over and present our findings to you. At the end of the formal presentation, we will have a Q&A. I encourage you to put your Q&A or your questions, that is, in the Q&A slot of the Zoom platform. If they are questions about the survey itself, I will turn them to Catharine to answer. If you have more general questions about lymphedema, diagnosis, management, prevention, anything that may be on your mind that I can help with, I will be happy to answer those. So with that, I'm going to turn the podium over to Catharine so that she can tell you the results of our exciting study.
Wonderful. Thank you so much, Dr. Rockson. I'll just start by sharing my screen here. Wonderful. So good morning, everyone. We're very excited to present this work as introduced by Dr. Rockson with our talk entitled Lymphedema, What Do Patients Experience in the Healthcare System? So as Dr. Rockson had explained, this research was born out of an effort to objectively document lymphedema, what lymphedema patients are telling us about their experiences with lymphedema. And, as many of you likely know all too well, lymphedema patients are often encountering a lack of awareness within the medical system. And as we see kind of to date with most of the medical literature, we've seen that it's described, these interactions with the healthcare system primarily through kind of patient narratives or through smaller studies, perhaps on the magnitude of 10, maybe upwards of 100 people. So what we set out to do was try to aggregate and quantify these experiences from across a sample of not 10 or 100, rather to the magnitude of multiple thousands of individuals. And so, as mentioned, as this was done, there was a 23-item questionnaire that was sent out anonymously to individuals who identified as having lymphedema, primarily through social media in partnership with LE&RN. And we were able to collect data that was, again, anonymous in pertaining to clinical characteristics. So, what kind of lymphedema someone might have, healthcare experiences and interactions, and then patients' level of satisfaction with their healthcare and their quality of life. So in each of the next segments of the talk, I'm going to share with you the results of our polls that were taken before with the larger social media group. So we've had an overall response rate in this study of almost 2,200 participants, which for a survey of this type was certainly a very rewarding sample size, and it allowed us to draw some robust conclusions. We did note that of these participants, about 6 folks did identify as not having lymphedema. Of course, this was paradoxical that they would be participating in a survey on lymphedema, so we did not include their answers in this analysis. But our first pie chart here, as you can see, we actually had almost equal proportions in participation from cancer-related and non-cancer-related lymphedema patients, with slightly more cancer-related lymphedema patients partaking in the survey. And so the first set of responses pertain to those with cancer-related lymphedema. So this first slide here reflects, clinical studies that have been performed in the past have shown that there is an increased likelihood of developing lymphedema if both lymph node removal and radiation were performed as part of cancer treatment. And you can see that our data is reflecting this literature as well, with the majority of cancer-related patients, lymphedema patients, reporting that they did have both lymph node removal and radiation therapy undertaken prior to developing their lymphedema. And as we discussed earlier in the presentation, clinicians are often told, cancer survivors have not been either educated on lymphedema prior to their cancer treatment or had, any educational materials given to them. And so our data were actually in keeping with this concept. And we noticed that about 66% of participants with cancer-related lymphedema reported never having had a discussion with their practitioners about lymphedema prior to cancer treatment. So that's shown on the left-hand side here. And that this phenomenon was actually the same as it related to being given educational materials about lymphedema prior to cancer treatment. Again, the grand majority of people said they were not given educational materials prior to cancer treatment on lymphedema. So this next piece of data reflects whether patients were given compression garments prior to beginning cancer treatment. So it's important to note that this is a widely but not universally accepted approach among lymphatic healthcare providers. And there are no formal studies of the efficacy of what's called prophylactic use of compression, but a recommendation can be made on the grounds that it doesn't necessarily carry an implicit harm and could be helpful as a preventative form of therapy. And so what you can see in the pie chart here is that the majority, again, 90% of cancer-related lymphedema patients who responded to our poll were not given compression prior to their cancer treatment. So this next piece of data here in aggregate basically shows that the majority of patients had no clinical attention paid to their lymphedema at the time of their cancer treatment compared to really any other option. So the question that was being posed was on the left here, were you asked about your lymphedema symptoms during your cancer treatment? And you see again, the majority were not asked about their lymphedema. And on the right here was, had you ever been examined for your lymphedema during cancer treatment? Just some technical information for you all, because you will see them again. These asterisks here demonstrate that we've run a statistical test to basically show that there is a difference between the number of folks here who said, I was never examined for lymphedema versus those who maybe had it done once, sometimes, or at each visit. Okay. So in terms of testing for lymphedema during cancer treatment, or that early detection after cancer treatment, our results on this slide are quite comparable to the last one, in that we saw the vast majority of participants, as you can see here, were never tested for early detection of lymphedema. So in the next portion of the survey, we asked about a number of different ways in which lymphedema can be assessed and measured. So that would have included, being measured by tape measure, pyrometry, bioimpedance, and then there was a portion of individuals, again, who said, I was never tested with any of these methods for lymphedema. And you can see of the people who were assessed for lymphedema, we had most folks, 38%, saying it was done by tape measure. Now, when we assessed the timing of when lymphedema appeared after cancer treatment, we confirmed, what's stated in the literature, and that lymphedema primarily developed within the first year after cancer treatment. We also noted that, there was a fairly even distribution of lymphedema developing over the course of, say, the first 2 years of treatment, as shown here. So I think, one of the important messages is that patients should be educated that lymphedema is not necessarily an immediate phenomenon, but they should be vigilant in the first 2 years after their cancer treatment. But furthermore, that they should be vigilant certainly beyond the 2-year mark as well. And so this question here that we were asking, or these pieces of data here, is again embedded in that idea that lymphedema often does not fall under one medical specialty. So we asked participants who were diagnosed, who actually diagnosed their lymphedema, just to see the distribution of the various medical domains that may be responsible for diagnosing the participant cohort. And so you can see about half of the individuals were diagnosed by someone outside of their cancer surgeon, the radiation oncologist, or their primary care physician. And further, that about 16% of individuals said, I was not diagnosed by a doctor. This was done either by somebody else, or I did not receive a diagnosis. So now we're moving on to the section of the poll that addresses, all lymphedema patients. And just to set a bit of a lay of the land as well, for the next several graphs, the white bars are representing folks with cancer-related lymphedema, and then the gray bars are representing the answers from people with non-cancer related lymphedema. And you'll see that these are kind of grouped into various categories. So in this case, for this bar graph, we're asking, who first noticed lymphedema? Was that the patient themselves? Was that a doctor or healthcare provider, a family member, or a friend? And again, you see those asterisks popping up to say that we've compared the number of people with cancer-related lymphedema to those with non-cancer related lymphedema by each category. And we see that over the course of the lymphedema experience, it's often that patients are acting as a primary advocate and driver of their diagnosis and seeking that out, as well as often their care. And so it's without surprise that we also saw that lymphedema patients were also once again a prominent force in the initial identification of their lymphedema as well. So as you can see here, and that there were significantly more cancer-related patients saying, I myself identified the lymphedema compared to those with non-cancer-related lymphedema who maybe had an external party more likely to identify their lymphedema compared to the other group. And this question was similar to the one that we saw for cancer-related lymphedema patients, to look at the delay in diagnosis after the onset of lymphedema symptoms. Again, just a reminder that the white bars are representing answers from cancer-related lymphedema patients, and the gray is for non-cancer-related lymphedema patients. And our groupings here are the folks who said, it was about 0 to 1 months between when my lymphedema symptoms showed up and when I received a diagnosis, 1 to 3 months, 4 to 6 months, 7 months to a year, or more than a year in time. And as you can see, it appears that non-cancer related lymphedema patients experienced a significant delay, with the majority being diagnosed after a year, whereas most cancer-related lymphedema patients were primarily diagnosed within that first 6 months. And what's interesting here is that this pattern is a phenomenon that, to our knowledge, has not been documented upon in the medical literature, and especially not at this scale. So we're quite motivated, of course, to share this with you all and the further medical community as we increase our advocacy efforts here, for sure. And so our next set of data here relates to the fact that lymphedema patients, as mentioned before, they're often triaged through several doctor's appointments before receiving their lymphedema diagnosis. And similar to the last figure, again, the colored bars indicate the type of lymphedema, and our groupings here are reflecting how many doctors a participant may have seen prior to receiving their diagnosis. So 1 doctor, 2 doctors, and so on. And so what's most striking, I would say, about this set of data here is that the cancer-related lymphedema group overwhelmingly required only 1 consultation from a doctor prior to receiving their diagnosis. There, of course, is a bit of a spread here, but you can see that about 54% of our participants had said, it was only 1 doctor's visit. Whereas in non-cancer-related lymphedema patients, they were seeing, mostly upwards of 4, 5, if not more doctors prior to receiving that diagnosis. And you can see from the asterisks again here that this is quite a significant difference between the 2 different groups. And so our next set of data here is about the referral to a lymphedema therapist. So as you can see here, there was a smaller but still notable percentage of our participants who were never referred to a lymphedema therapist, either by a healthcare provider or say by their own self-initiated visit. This, of course, is in contrast with our standard of care, where lymphedema therapy is kind of a hallmark of sustained management. And so we can certainly see an opportunity for intervention here in that we need to reduce, first off, the burden that's placed on the patients to self-refer, and hopefully have healthcare providers help to really streamline that care towards referral and eventual therapy. So finally, we looked at the delay between when symptoms appeared for lymphedema patients and when their treatment was actually received. And again, there seems to be actually quite a striking difference between the cancer-related groups who appeared to be receiving their treatment earlier on than those with cancer-related lymphedema, again with the gray bar, who were typically receiving care upwards of a year after they noticed their symptoms. So again, these are statistically significant differences between the 2 groups. Now, our final 3 survey questions that were sent out were actually completed using the sliding scale line that's shown here. And so just to describe the methodology behind that, in responding to the poll, participants could choose basically any point along the line. And in this case, saying, what was the quality of life impact or functional impact of lymphedema on you? And so they could say either, no effect or something a little bit in between, all the way up to it had a devastating impact upon me. And so what we did was we took all of the kind of points on the line and we averaged them. And it became quite clear that both cancer-related and non-cancer-related lymphedema patients had reported a substantial quality of life impact that lymphedema had upon them. And the overall response corresponded to about a 6 to 7 out of 10 in terms of devastation. I'll describe this because you will see them a couple times over the next few slides. These are called whisker plots, and these are just ways in which medical statisticians group data for statistical analyses, just so you're familiar with that. Again, for this next question here, it was a similar methodology in terms of that continuous line to respond, and then we can average the results here. And so what we're showing on this slide here is that patients with both cancer-related and non-cancer-related lymphedema had reported that the perceived interest of their physician regarding their lymphedema was only about 3 out of 10. So in other words, patients were perceiving that their doctors were relatively unconcerned with their lymphedema. And then the final piece of data here is, again, that similar methodology with the sliding scale or the continuous line. And in this case, what we were looking at is patient satisfaction with their lymphedema diagnosis and treatment. And you can ultimately see that both cancer-related and non-cancer-related lymphedema patients felt a relative sense of dissatisfaction with their lymphedema diagnosis and treatments, with an average response of, say, about 4 to 10 in terms of their level of satisfaction. So this slide here is basically what's called a schematic, or it would be a photograph or a bit of a flow chart here of patients' interactions with the healthcare system. And this is based upon all of the data that we've collected over the course of this questionnaire, and trying to really look at a care pathway for patients through the medical system. So the asterisks here denote points of interaction where patients are interacting with the healthcare system. These little clocks are indicating points of delay as documented within our survey. And just to explore a couple of observations with you all here, basically the schematic does emphasize that there is, relative uncertainty that are faced by non-cancer related lymphedema patients, especially at the initial phase of their lymphedema journey. As you can see, we have cancer related lymphedema patients having several points of interaction in their care. The schematic also shows, there's quite a range in the nature of the interactions, as well as a much higher number of physicians seen by cancer-related lymphedema patients compared to the non-cancer-related lymphedema patients. But the important takeaway would be that regardless of the origin of lymphedema, our data did show that despite these differences in the journey through the medical system, both groups still reported a substantial decrease in quality of life and dissatisfaction with their lymphedema care. Furthermore, what we can see in the schematic is that, a complete reinvention of how the healthcare system is structured is certainly not needed to provide timely, quality lymphatic healthcare to patients. We have several points of interaction across both groups that can be intervened upon. And so we can, potentially streamline our care to ensure patients are passing through this care continuum in a timely manner in order to reach sustained self-management as soon as possible so that we can improve overall patient outcomes. And just to kind of some concluding remarks is that, we saw in the survey, and it certainly aligned with the literature as well as what we hear clinically, that lymphedema does have a substantial impact on patients' well-being, but they continue to face barriers to their lymphatic care. Our study was the first formal attempt to validate and numerically quantify patients' interactions and their levels of dissatisfaction with the healthcare system. That really emphasized the need for both research and reform in order to improve lymphatic education as well as healthcare. Well, with that, I wanted to thank you all so much for your time and your attention, for your active listening and participation. We are very, very excited to share this information with you and look forward to also sharing this in the form of a publication, hopefully in the near future. And yeah, so I'll wrap up here and open the floor to the Q&A as well. Thank you.
Okay, we can unshare the screen, I think. Thank you so much, Catherine. That was a lovely summary of our data, and thanks to the audience for participating in the survey, which will certainly strengthen the data further and make it even more publication worthy. Before I launch into the questions that are present, I want to give you my perception of the 20,000-foot view of the data that you've just heard to put it into context. I've been practicing lymphatic medicine now for close to 30 years, and subjectively, I've heard these stories over and over again about delay in diagnosis, lack of concern, multiple physicians, all of the problems with the healthcare interaction that are simply not acceptable for such a common disease. This does not appear anywhere in the medical literature. And we, in the practice of medicine and the practice of medical science, do not rely on anecdotal data to guide us. We need objectification. Catharine and I have now objectively documented that this is a problem in almost 2,200 patients like those of you that are on the call today, on the webinar today. This is going to exist in the medical literature. Ideally, this is going to drive reform, which is what the CDC is after. We need to educate healthcare providers on the importance of this problem and what they should be doing to interact with it. So we're very proud of this work. We will present it at a number of meetings as well. And hopefully this is going to have an impact that's sizable. I'm now going to look at whatever questions we have in the Q&A. If it's related to the study data, I'll turn them over to Catharine. If you have general questions for me about lymphedema, its diagnosis, its management, its prevention, of course, I'm happy to answer those. So the first question is, where do I send all my clients with lymphedema to answer all your study questions? And this study is finished based on today's analysis of the poll data. And hopefully LE&RN will be able to publicize your reactions as a group separate from the manuscript, which may not be accessible to all of you. Basically, we consider this to be a very statistically relevant sample of the population. This is a valid study with 2,200 participants. This is like taking a slice of the pie and saying this is an apple pie. We basically feel that we have put a period at the end of the sentence. And of course, there will be other studies, but this one has been concluded. Are there any drug-related treatments for primary lymphedema available currently? There are no drug-related, no drug treatments available for lymphedema in general, as far as being able to go to your neighborhood drugstore and pick up a prescription. Many of you know that I've been working on this topic area now for over 20 years. We feel very close to the point that we will have commercializability of the work that we've been doing, first in animals and then in people. There is an active breast cancer-related lymphedema trial at Stanford, a single-center trial under the auspices of the FDA, and that is briskly enrolling, and we hope to complete that trial next year, which will be an important step toward commercial availability. I also have been given the opportunity by the FDA to conduct what is called an expanded access protocol, meaning individuals who are not eligible for the trial, and that would include primary lymphedema, are theoretically eligible under select circumstances to receive the drug that we are testing in clinical practice under close surveillance. So that's a partial answer to your question. I hope I can come back in another couple of years and say, yes, there is a drug, and this is the name of it, and this is where you get it, and this is what it will do. We're almost there. Somebody asked where to find an update on my research on using NSAIDs to manage lymphedema. Well, I need to say several things in that regard. Number one, my research is not about NSAIDs. It's about a very specific NSAID called ketoprofen. NSAIDs is a very large group of drugs that share a lot of properties, but there is only one in that entire group that is able to accomplish the goal of reducing lymphedema, and that's ketoprofen. Ketoprofen is a prescription drug. And the bad news about the ketoprofen work is that after we published our data, after many years of work on it, the FDA determined that NSAIDs in general are dangerous. They are dangerous to the general population because of cardiovascular risk. And if anybody uses over-the-counter NSAIDs, if you pull out the package insert, you'll see that there's a black box warning there that tells you that you should not take this drug chronically without concern for some of the adverse events that can happen. It is for that reason that we have followed another path. And the drug that we're currently testing has a similar action in the body to ketoprofen, but actually is an enhancement insofar as it doesn't share any of the NSAID risks, and it may be actually much more targeted to lymphedema than ketoprofen was able to be. The work is ongoing. I just want to reassure everybody that we haven't dropped the ball, and you're not hearing anything right at the moment because the data collection is actively underway. Somebody asked the question, I didn't realize that diagnosis may be necessary to obtain treatment. Should I ask my physician for a definitive diagnosis? The answer is yes. In the practice of medicine, treatment of a condition follows on diagnosis, and the diagnosis predicates the treatment if there is a treatment that's available for the diagnosis. To simply treat on the basis of an individual who has treatment skills but no diagnostic skills is suboptimal. Unfortunately, that, as you saw from our data, is what happens most commonly in the United States. Patients go directly to a physical therapist by whatever route they find them. The physical therapist, who is not strictly speaking licensed to deliver a diagnosis, says, yes, you have lymphedema, I'm going to treat you in this fashion, and then I'm going to prescribe a sleeve for you, I'm going to prescribe a pump for you. All of these things fall outside of the general model of clinical care. In order to get insurance reimbursement, if it's available, it is preferable to have a physician's formal diagnosis. And it is also preferable that a physician be a physician or healthcare provider licensed in both diagnosis and treatment. So that could be a nurse practitioner or a physician's assistant, but not a therapist, not somebody who's simply licensed to deliver the therapy. They are phenomenal. They do invaluable things for our patients, but diagnosis is not within their purview. So if you think you may have lymphedema and haven't received diagnosis and therefore haven't been treated, get to a doctor who's willing to establish that diagnosis so the treatment can be undertaken. The next question, and it's probably going to be the last one, I'm afraid, because we've run out of time, is very relevant. And unfortunately, an answer that is not forthcoming from our data, but I think is certainly a phenomenon worth paying attention to. Somebody said, I'm wondering what the percentage is of patients that have been denied treatment because they cannot afford the cost of sleeves and other self-maintenance equipment. I just spent over $1,200 in day and night sleeves after aggressive treatment. This is unfair for people that cannot afford it. I cannot agree more wholeheartedly. Now, the good news is, for many of you that know this, historically, Medicare has not supported the cost of compression garments. This is based upon a defect in the original Medicare law where the diagnosis of lymphedema was not linked to the treatment code, and therefore Medicare would automatically deny it. That meant that a lot of third-party payers followed suit with whatever Medicare would do. After a 12-year struggle, the Lymphedema Treatment Act has finally been passed in December of 2022. It is currently under discussion with CMS, which is the managing body that oversees Medicare, and we expect that there will be formal guidelines for what will be reimbursed that will probably kick in by 2024. 2024, I'm imagining, maybe earlier. And we can hope that other third-party payers will follow suit as they have historically with Medicare in the years that have preceded. So this whole picture may change, but we have big healthcare inequities in our country, not only for lymphedema, for all diseases. We don't have universal healthcare, and we don't have universal health coverage. So many, many patients regrettably fly under the radar and simply do not get the care that they merit. This is a big societal reform that we need to undertake. It's been under discussion for every generation since I've been a medical student, and it still hasn't happened. So let's hope this current generation will solve the problem for lymphedema and everything else. With this, I'd like to thank everybody for spending the time with us. I'd most especially like to thank Catharine for an excellent job in summarizing our work. We're now going to get busy pulling all of your data together so we can finish up the manuscript, get this in print so that the healthcare system can make changes. They're dearly needed, and we hope we can be an instrument for change. The two of us as manuscript writers, and more generally LE&RN, which has always been looking out for you from its inception. So thanks very much for attending, and we will see you next time. Thank you.